Since the last session ran over, we'll give people till 9:50. We'll cut a couple minutes off of the discussion session. So starting in 2 minutes.
Hi, can we get everyone to take their seats, please, and we'll start the session? Great, thanks for your cooperation. I'm Brett Shepard. I'm a co-moderator with Randy Brand. I come from Oregon Health Sciences University, the Knight Cancer Institute. And we're going to start out with our first presentation. We have you take your seats, please. Thank you. Okay, our first presentation is from Dr. Yadav, the University of Pittsburgh Medical Center, and he'll be talking about outcome measures for clinical trials in recurrent and acute pancreatitis.
Good morning. Thank you, Dr. Shepard. It's nice to be here in Hawaii, and I hope that you all are having a great meeting and time in Hawaii. My assignment is to talk about outcome measures for clinical trials in recurrent acute and chronic pancreatitis. These are my disclosures, which are not related to my presentation today. I'll initially review the clinical profile of chronic pancreatitis, especially as it relates to consideration for outcome measures. I'll review some of the challenges in conducting clinical trials in RAP and CP, review some of the completed and ongoing trials, and spend some time on a proposal for core outcome measures that have been put together for consideration for the community. So the figure on the left shows the clinical course of patients with chronic pancreatitis. It is important to emphasize that this is a chronic disorder that evolves over years, as shown on the x-axis. The most common symptom in patients with chronic pancreatitis is pain, present in about 90% of patients at some time during their clinical course. And importantly, abdominal pain, because of that reason, is the predominant outcome measure that is considered for treatment because it impacts patients' quality of life. The other outcomes to consider are other events in patients with chronic pancreatitis, importantly, episodes of acute pancreatitis. In general, the frequency of these attacks decrease over time, and also the severity is attenuated. Then there are other outcomes to consider would be loss of function in terms of diabetes or exocrine insufficiency, need for surgery, hospitalization, ED visits, and others. There are several challenges that we all recognize, those of us who are in the field for a long time in conducting clinical trials in RAP and CP. Perhaps one of the most important is the lack of standardized outcome measures. Because if we have standardized outcome measures, then that would allow us to compare results of individual clinical trials, learn from them, and refine them over time. I'm just going to use abdominal pain as an example. And John Windsor and his group, and John Windsor is here in the audience, they've really done a tremendous amount of work over the past 10 years for us to get an understanding with regard to where the field is. About 10 years ago, they put together a systematic review where they looked at all human studies that have evaluated pain, and specifically for outcomes of pain treatments in these patients. Of over 125 clinical studies, there were about 35 clinical trials that they identified, and they organized the pain assessment tools into those that were general or those that are disease specific. Most of you will recognize the SBQ pain score, which is most commonly used in surgical trials over time. But then what they did is they organized these data, and the first column is the different aspects of pain that are important for us to consider to get a comprehensive assessment of pain in a patient. And on the other columns are individual pain assessment tools. And it is very clear that all of these tools have limitations in terms of what different domains or aspects of pain that they are recognizing or identifying. Based on these, they put together the comprehensive pain assessment tool, or COMPAT, initially a long version, and more recently a short version, which has now been validated and starting to be used in trials. Other challenges include the definition of the disease itself. How do you define chronic pancreatitis? How do you define disease at an earlier stage for use in clinical trials? Individual outcomes are important. For example, acute pancreatitis events are idiosyncratic, and it may take a long period of time of observation for us to really understand whether we are making an impact on a clinical course. Tanya Gonska brought up a very good point yesterday in the talk about CFTR patients. So if you have patients who have a very high burden of disease, in those patients, you can use attacks of acute pancreatitis in a modest period of time to show a difference. But that may not be applicable for the overall population of patients with RAP and CP that we are considering. And then we know that these are low prevalence diseases. So and within an individual disorder, there are heterogeneous groups. And as we start clinical trials, we very quickly realize that recruitment becomes a challenge for these trials. These are examples of 6 clinical trials that have been conducted in the past 5 years that have focused on abdominal pain. The top 2 you'll recognize on the left is the SHOKE trial, and Dr. Talukdar is likely going to review some of this later in this session. The other is the ESCAPE trial from our Dutch group. Both of them use mostly similar assessment for pain over time, but then you have other trials, for example, the CBT trial that Tanya Palermo led for our CPDPC consortium, a pilot trial. Then the trial on Camostat that Phil Hart led for an international group on Camostat and impact of pain. So again, the measures that have been used have been different. So how do we address challenges in clinical trials for RAP and CP for outcomes? I think the most important thing for us is, as a community, to define and standardize, or at least agree upon, what are the outcomes of interest that we should consider and use them consistently over time so that we can learn from them. Secondary is to characterize the clinical course in terms of quantification of events that are occurring, so then you have some measure in terms of whether you are making an impact when you are doing an intervention. An example of this is the COP score that was put together by our German colleagues a few years ago that I know is being used in a couple of studies. What I want to spend a few minutes is an effort over the past 2 years that is ongoing, and I really want to give a shout out to Mission Cure for taking this on. Lola Rahib has collaborated with Tanya Palermo at the University of Washington to develop core APCP program. And they have then collaborated with the CPDPC consortium and colleagues in the adult and pediatric chronic pancreatitis working group. The goal of this program are threefold. The first is to identify the domains that the patients and providers consider to be important for clinical trials in RAP and CP. Second, once the domains are identified, what are the specific measures that we should consider for each individual domain? And then the third is, once we put together this, then to take it through the FDA qualification program, so FDA recognizes and approves that these are the right measures for us to use. So this program has 4 components. The first 2 are focused on aim 1, where a Delphi process was used in 2 rounds to reach out to patients and providers to understand what are the domains of interest, then to evaluate assessment measures, and then the FDA program. And I have listed the members of the CPDPC consortium that are part of the steering committee for this program. So this paper now is available in Pancreatology online. These are the results. So in the first round, we reached out to patients, which predominantly came from Mission Cure Registry, adult patients or pediatric patients or their parents, and adult and pediatric providers. What was asked of them is to list what are the things that they would want to consider or they consider important to assess in clinical trials for RAP and CP. When we got the data, then the committee reviewed this information and organized this information in terms of what are the outcomes that are of interest. In the second round, those who responded to the first round, they were sent back a questionnaire again and asked, from these list of outcomes of interest, prioritize them in terms of 1 to 10, what is the most important, and what are the 5 most important outcomes that you consider. And this information then was again analyzed and put together in the framework of OMEREC guidelines that have been used in rheumatology, in rheumatoid arthritis, in terms of outcome measures of interest. It has also been used in pediatric pain in a similar fashion. So to review with you, the domains that have been identified are mandatory domains. That means they should be used in all clinical trials. Specifically, they were divided into 2 domains that are important for all clinical trials in terms of, irrespective what is your treatment treatment that you're using. So that includes assessment of pain severity, ability to participate in social roles and activities, pancreatitis-related hospitalizations of flare-ups, and then adverse events. Now, other mandatory items would include, depending upon what your intervention is. So if it is a nutrition trial, then you look for specific measures of nutrition, you add those to these mandatory ones. Next set of domains, they are important but optional. So for example, if you're doing a diabetes trial, then you can add those measures that you feel are important, or opioids and details of opioids. And then research agenda items. These are measures or domains that are important, for example, including biomarkers, so that you can generate exploratory data and then to look at impact on biomarkers for the treatments that you are testing. The second aim then focuses on identifying individual measures, and this work is actually pretty advanced stages. They're using a cost-min approach where experts who can evaluate the patient-reported outcome measures that are available and then provide and organize this information in terms of evidence-based approach as to what measures are important. And here is a list of measures that have been identified. Again, COMPET-SF is an important outcome measure for pain, in addition to brief pain inventory, some of the PROMIS instruments, and then pancreatic exocrine insufficiency questionnaire. I also want to point out that in the last 15, 20 years that I've been in the field, this is really a very exciting time for all of us, because the field has really moved along. And there are a number of clinical trials that are ongoing. I list here over 10 clinical trials that are identified through clinicaltrials.gov. This is not a comprehensive list because this does not cover all regions of the world. But there are several clinical trials that are ongoing. The large majority of these are pilot clinical trials, which is okay. Two of these will provide definitive data. One is the IMPACT-2 trial on the impact of cognitive behavioral therapy in adult patients. Second is the PQST trial as a predictive measure for endoscopic therapy or surgery in patients with obstructed disease. I highlight the top 5 clinical trials because these are being done as part of the CPDPC consortium. This would not have happened if NIDDK did not really invest significant resources in bringing together clinicians, translational researchers, and basic scientists to come together and work together. So this has been significant progress in the field, we believe, and the outcomes we are going to see in times to come. So in summary, there have been major challenges for us to conduct clinical trials in RAP and CP. The most important reasons for those are a lack of standardized outcome measures, and we do not have a good handle with regard to the burden of disease in individual patients or group of patients to quantify events. The clinical trials in CP and RAP have focused mostly on pain. Most importantly, for surgical outcomes or comparison with endoscopic therapies with limited data on medical therapies. There is a new proposal for core outcome measures that now is published. Our suggestion is for all groups to consider incorporating these outcome measures in clinical trials. Once we start seeing data, then we can discuss with regard to whether we need to refine them and how should we refine them, how can we improve them so that we can all learn along the way. Thank you very much.
Thank you, Daraj. Just like the sessions yesterday, we'll have all the speakers come up for a panel discussion at the end. Our next speaker is James Bucksbaum, who is an associate professor of medicine at USC, and he's going to speak on the promise on the closer to the end with clinical endpoints for acute pancreatitis.
So thank you for this tremendous opportunity and wonderful to see you all here. So we're going to be speaking about the endpoints for acute pancreatitis clinical trials. So in terms of the pharmacotherapy and drugs we can give for acute pancreatitis, relatively recent Cochrane meta-analysis of 32 studies show that there's no consistent benefit of any drug that's been tried yet. And since that's been published, there's been another 14 agents, another 14 trials looked at, and they've also been null. So right now we have no drugs for acute pancreatitis, which is unfortunate because it's one of the most morbid conditions in the whole field of gastroenterology. But I'd argue that we're getting closer to the end. So you can see the mountain there, Haleakala, in the distance here on Maui, and we're slowly climbing up it. And today we're going to talk about the challenges of these trials. We're going to talk about why things are looking better with endpoints. And then we're going to talk about a few recent trials where we've rolled out some of these endpoints and how it's working for us. So is it that the interventions aren't effective, or we've been looking at the wrong endpoints at the wrong time? You know, is it really a failure of therapy, or is it a failure of the way we've been designing these studies and looking at our data and thinking about it? So based on the National Cancer Institute's definition, an endpoint is an event or outcome that can be measured objectively to determine whether intervention is beneficial. And they cite that examples include things like survival, but also more patient symptom-related outcomes like improvement quality of life and relief of discomfort. So one challenge of acute pancreatitis, it's usually mild. So two big prospective multi-center trial groups, the Atlantis Consortium and Apprentice, show that the mortality is less than 5%, single organ failure less than 10%, multi-organ failure less than 5%. These are sort of the key outcomes that Santi Vega outlined and what really should be the main outcomes of acute pancreatitis trials. And our prospective cohort at LA General Hospital, which is more of a huge community hospital in a sense, it's even lower. Our mortality is less than 2%, and our multi-organ failure is 2.6%. Now, the challenge of that is that these are low event rates. So when anyone who's worked with designing trials knows when you're looking at things that are 2 or 5% and you're trying to lower that, you need a very large sample size. And the problem with that is there's been quite limited federal funding for acute pancreatitis intervention trials, I think almost none. And until very recently, there's been very little pharmacologic company funding as well. So we've relied on things like surrogate and composite endpoint, which has been a challenge. I'll cite my own faults here. Here's a trial we published looking at aggressive or moderate hydration. You can see that organ failure happened in hardly anyone. And so we relied on hemoconcentration, which not surprisingly, if you give a lot of fluid and dump in more, you'll see less of that, less hemoconcentration, and clinical improvement, which is a composite outcome, but includes hemoconcentration. So the driver behind that, again, is these surrogate outcomes, with good faith, but just given the limited sample sizes we could achieve, we end up using things like that can be misleading. Even the really great trials in the pancreatology literature have used a lot of surrogate things like serum IL-6 levels, change in CRP, which are good, but they probably don't really get to the crux of what we're trying to avoid. In reality, do you really care if your patient's IL-6 was higher or lower on day 2? Not really. You really want to see if they get organ failure or something bad happens to them. Another challenge is that pancreatitis is an uncontrollable chain reaction, and all those that do ERCP worry about, when we cause it and what terrible things can happen. We see Marty Freeman's in the room, the world expert in this, and it's an unpleasant thing when it develops, and partly is you don't know when it's going to stop. So it could just be intracranial, just a little mild pancreatitis. It can go around the gland and cause necrosis, or it can just go, completely everywhere. You have a systemic organ failure and death. So that's also a problem. Now for the mild cases, it biases you to the null. If the patients all get better in 3 days, it's very hard to see anything happen with an agent. If it's severe, you don't really know what's going to happen. Lexapufant's an example, is a platelet activating factor inhibitor, and they tried to capture severe patients. So it's Apache 6 was the enrollment criteria, but they allowed patients to come in up to 3 days later. And what happens by then is it's kind of like Chernobyl there. And once it's destroyed, you're really just doing a salvage trial. You don't really see much. 57 versus 58% organ failure. It's hard to interpret. So can we predict things? Well, it's been a huge effort in prediction. You can see there are several dozen of these scoring systems, and there's problems. Some require 48 hours to interpret. Some require expensive tests, like L6 aren't widely available. Some are very cumbersome, like Apache 2.0, where you have to get a GCS plus an arterial blood gas plus 6 other things. And some are subjective, what's really 30% versus 40% necrosis on CT, hard to say. Even combinations are problematic. The Pittsburgh group did the Munzer rules, and these are improving the AUC, but they're very cumbersome to apply. Additionally, looking at normograms of all these factors and all these predictive scores, and this is from a meta-analysis done by the kind of big European pancreas group, the best you could do is you can raise your post-test probability to about 50%, but it's still a coin toss. A little better for negative predictive value. You could rule it out in most patients, but it's still hard to predict who's going to get pancreatitis. But I'd argue that things are looking better. Here in Maui today, it's a beautiful day. This describes kind of the sentiment in the pancreatitis community that things are getting better. If you look to the cardiology world, they kind of got the clues earlier, early enrollment, multi-center groups to have real power in their studies, and argue that we're starting to do that. For example, in the Mosaic multi-center trial, we have a pancreatologist paired with an ER doctor. So you get alerted early when the patient comes in. There's multi-center collaboration. In part, this is due to the NIH with DREAM and CPTCC. But also in the US Pancreatic Study Group, I think Dr. Wilcox is here, who's organizing that, but also around the world, the Dutch group has done very well. There's a Chinese acute pancreatitis clinical trials group, the Thymosin study, the Goulash group in Hungary, and then the multi-center group that Enrique's organized with Erica. Importantly, we do also now have a consensus endpoint with revised Atlantic classification. And so as many of this group developed this, it involved 11 societies that came together. It defined organ failure with modified Marshall score, systemic complications of worsening of underlying comorbidities, more clearly define these kind of 4 classic peripancreatic complications based on absence or presence of necrosis and time. Again, with peripancreatic necrosis evolving to pseudocyst, peripancreatic fluid collection evolving to pseudocyst, and acute necrotic collections evolving to walled-off necrosis, which is something that even a savvy medical student can interpret to help out with clinical trials. It's a clear definition. Also, gastric outlet, splenic portal vein, and colonic necrosis are included. But the important point is it's defined clearly what is the severity, mild, moderate, and severe, in a way that can be replicated. There's also determinant-based classification, arguing that there's certain determinants like infected necrosis or organ failure that drive the adverse things that happen. These two have been compared. They both have been validated. There's probably a little better uptake of the revised Atlantic classification, just given that it does correlate a little bit better with who has morbidity versus who actually dies as mortality. And that the severe group of RAC is really the high mortality group, whereas the severe group of the determinant-based classification is kind of a mix of morbidity and mortality. So we've kind of seen the emergence and really with the revised Atlantic classification. Additionally, patient-reported outcome measures have evolved. This is really an interest by the FDA, to say what the patient actually reports and emphasize how important this is. And Enrique and his group have really developed the PAN promise, looking at domains of acute pancreatitis and what's important to patients and scoring these. And indeed, this does correlate with readmission. It correlates with severity and other important outcomes. Beach and others have worked on the PAS score. And the idea here is akin to what goes on with the Crohn's and colitis world. There's actually a measure of how active pancreatitis is now. And this can be used in trials. And this was derived with a RAND process. And there's initially 5 domains, and this did correlate with severity, correlate with readmission in multiple centers, and has been implemented now in clinical trials as well. The MPAS-1 is a revision that excludes the morphine equivalent, just to really kind of both validate and then improve the performance of this scoring system. I'd also argue we have improving prediction as well. There's a Hawaiian island of low heat they've been talking about for many years. 50 years ago, the only prediction model was looking at graphs of where the current islands are. You can see up in the left upper corner. But now we have all these new things like bathymetric mapping and other things. They've actually now been able to find the emerging volcano underwater by using much more sophisticated methods. Kind of what we're doing in the acute pancreatitis world. Artificial intelligence and machine learning are really driving this. So one common software package that's being used a lot is the extreme gradient boosting tree, which basically is like the old tree leaf models, but it actually allows multiple different iterations and cross-validation very rapidly. And a number of companies, like this one's from Descensa, they publish this in Pancreatology, have used this to identify groups of features that are very highly accurate with the input of patient data in a very automated and iterative way. And you can see that on the right, the Shapley out of explanation plot, which you're going to see more of a SHAP plot. And what it is the reds are strongly predictive, the blues are negative predictors, and the grays don't go either way. It allows very rapid processing of tens of thousands, hundreds of thousands of patients, and then they can be taken forward. The Easy app is from Dr. Hage's group, is a similar thing using XGBoost and again SHAP plots to try to really predict using many features of these patients. ADAPT is something we worked on here with Dr. Whitcomb's group and Aerial Dynamic, and this similarly uses machine learning to look at everything from the patient's cellular function to interaction among organs to predict what happens. It calculates more than a dozen scoring systems. It even gives recommendations. We piloted this a bit at LA General Hospital. Indeed, it does predict pretty good. You can see that the likelihood of severity, it does appear to really correlate with what happens to the patients. And it even makes fluid recommendations. You can see in the study that Nguyen Kong in this data did, we could see that the respiratory failure was much more common when we didn't follow the fluid recommendations of ADAPT versus when we did. So these are being implemented, and I think we're seeing improvement. We did look at NS versus LR initially, several small studies, and then at LA General, we looked at this. And you can see that we were looking at SIRS and persistent SIRS based on stuff that came originally out of Beach and Wu and Peter Banks's project, but we did also define revised Atlantic classification. And we didn't see a difference, but the good thing is that there's synergy that the 4 other groups also looked at revised Atlantic classification. So then when you do meta-analysis, you can then see if there's somewhat more of an impact. So in meta-analysis, it did lower the moderate and severe likelihood of pancreatitis. And then the advantage of this is that then for the next trial that we're doing with Dr. Madera leading again, what's we call the Waterland trial, we were able to power this based on then the meta-analysis. So by speaking the same language and having endpoints, I think the field is moving forward. Waterfall did also use revised Atlantic classification as the main outcome. This wasn't hit because the safety outcome was first hit with more overload in the moderate arm. But Waterland also illustrated the use of these more patient-centric outcomes. Pan Promise was a major outcome. And actually using the design, a Pan Promise less than 5 rather, was used to determine when the patients could be fed. For pharmacotherapy, I believe we'll hear about this meeting some more, but with the calcium release activated channel inhibitors, we recently saw some results from the phase 2 study, the CARBO trial, which is the agent being absorbed, which is a crack inhibitor. And for the CARBO trial, you do see that we again use symptom-related outcomes, right? To look at when patients can eat, time to solid food tolerance. And for the more key groups of particular doses and the agent, this is helpful to kind of guide where the future trials will go. And again, it's something that patients care about. Similarly, we looked at the proportion of patients remaining in the hospital, another important patient-centric outcome. And of course, there were the classic things of organ failure, although again, these are a little harder to find, but in phase 3, now these can come out more with potentially significantly less respiratory failure. So in summary, why are we closer to the end with clinical endpoints? You know, the challenges again have been the low event rate. It's been these surrogate and composite outcomes. There's been salvage trials in severe pancreatitis, and the disease course has been challenging to predict. Things are looking better in that we have better trial design, catching patients earlier. We're working with multi-center collaboration. We're using consensus definitions for outcomes, which allows us to translate these among groups around the world and to harmonize results. We're using more patient-based centric outcomes like PanPromise, and we have better prediction technology, which is likely going to get even better. And we're seeing it already in action with NSLR and Waterland, the RAC, with Waterfall, the RAC, but also PanPromise and symptom-related outcomes. And then in CARBO, it shows the emerging importance of patient-important outcomes in FDA trials. And I think we're going to see a lot more of this, and I think things are going to get better. Thank you.
Thank you, Dr. Buxbaum. Our next speaker is going to be Dr. Lee, who's coming to us from Stanford University, where she is an instructor in pediatrics and gastroenterology. And she'll be speaking to us about the state of circulating biomarkers in pancreatitis.
Good morning, everyone. First of all, I'd like to thank APA organizers and committees for inviting me to give a talk in this session. I'll be talking about the state of circulating biomarkers in pancreatitis. So first, identifying biomarkers in pancreatitis is significant given the fact that the global incidence of acute pancreatitis is increasing over time. Clearly, pancreatitis is a global health problem. And AP, acute pancreatitis, can progress to the severe acute pancreatitis, SAP, which carries multiple organ failure and mortality. So it will be identifying biomarkers that can predict SAP will be very much helpful for timely management of those patients. Another fact is that the pancreatitis is progressive disease. And as you know, CP can be progressed from AP and RAP, recurrent acute pancreatitis. About 20% of the AP transition to RAP, and then about 35% of the RAP patient transition to the CP. Actually, this progressive disease giving us opportunity to identify early diagnostic prognostic biomarkers in pancreatitis. However, there is no reliable early diagnostic prognostic biomarkers or therapeutics for pancreatitis. Then what are the known biomarkers and biomarker candidates for AP and SAP? For the AP, as you know, serum total amylase and lipase are gold standard for the diagnostic of AP. And other than those, trypsinogen activation products, CRP, elastase are also known to be potential biomarkers. Immune markers including IL-6, IL-8, IL-10, these are also reported as potential biomarkers for AP. For the SAP, major feature for the SAP is exna ductal cell injury and then necrotic cell death. So those end products, double-stranded DNA, HMGB1, T-cell protein, these are also known to be potential biomarkers. Immune markers, including IL-1 beta, IL-6, TNF, these are also reported as a potential biomarkers for SAP. Then what about CP? As you know, fibrosis is major feature for the CP. So fibrosis-related molecules, TIMP1, MMPs, TGF-beta, and PDGF, these are also known to be potential biomarkers. And also prolonged oxidative stress is also known to be major feature for the CP. So lipid peroxidation related molecules and antioxidation related molecules are also reported as potential biomarkers for CP. Similar to AP and SAP, inflammatory cytokines, including IL-6, TNF, IL-1 beta, these are also known to be biomarker candidates for CP. And other than those, adipokines, metabolites, and microRNAs are also known to be potential biomarkers for CP. Then question is, why do they remain potential biomarkers? As you know, there are several steps on the bench side research and also clinical translational steps. Majority of the biomarker discovery research couldn't move forward from bench to bedside because they failed this validation step of the biomarker candidates. Then what are the factors that affect the pancreatitis biomarker discovery and validation? I came up with 3 factors. The first of all, disease state. Sample collection timing is very important. For example, the samples are collected from the inflamed state versus quiescent state. The results can be very different. Sometimes the mixture of the etiologies can give us variability in the outcomes. For example, alcoholic, idiopathic, hereditary pancreatitis, their circulating molecules can be very different. Sometimes the disease nature and disease complexity can give us hard time to identify biomarkers. For example, slow destruction of the gland and the fibrosis in chronic pancreatitis significantly impair the secretion of the pancreatic enzymes and bioproducts, making those secreted molecules unreliable as biomarkers. Secondly, the methodologies. Even though using the same samples, different technologies can give us different results. Among the similar assays, sensitivity of detection also affect the result as well. And sample processing and sorting methods also affect the results. Lastly, the cohorts. What kind of controls are used for the comparison, whether they are age, gender matched healthy controls or not. And also, limited number of cohorts can skew the data and affect the results as well. Next, I'd like to introduce some of our research efforts for the biomarker discovery in pancreatitis. This study was published last year. We used serum immunoassay Olink technology to evaluate the circulating immune responses in different states of the pancreatitis, AP, RIP, and CP. We use PROCEED cohort, CPDP's PROCEED cohort. Then uniqueness of this cohort, the majority of the samples are collected from the quiescent state of the pancreatitis. So this cohort gave us opportunity to evaluate whether the circulating immune responses are altered during the quiescent state of the pancreatitis. Interestingly, we found that innate immune signaling and pro-inflammatory cytokine signalings are accumulated over the disease continuum from AP, RIP to CP. Not only that, environmental risk factors such as smoking and alcohol can also alter the circulating immune responses in this cohort. Next, novel technologies improve proteomic sensitivity for biomarker discovery. As an example, the Stanford HIMC Human Immune Monitoring Center recently performed the cross-platform comparisons of 3 different immunoassays. Nirajasic, Olink, and Luminex. Using the same cohort, they evaluated same inflammation panel. They have shown among these three different immunoassays, they have shown different detectability and sensitivity of the detection. So this study actually highlights the importance of using the right and sensitive immunoassays for our biomarker discovery study. Next, what are the novel types of biomarker candidates and technologies? The technologies have evolved to detect the small molecules such as cell-free DNA, non-coding RNA, microRNA, exosomes, and metabolites. Actually, it's very challenging to detect these small molecules because they have diversity and heterogeneity in their size, concentration, and their molecular composition. So technologies have advanced to detect these small molecules using the miniaturized detection devices that use microfluidics and the nanoparticles. Actually, these novel technologies allow us to detect these small and rare and specific molecules as biomarkers, minimizing the amount of blood we need, but maximizing the use of our precious samples. Next, standardizing biospecimen processing protocols are also important. As one of our research efforts, our undergraduate student, Cordelia Lee, has worked on a comprehensive review of the biorepository information from 7 different US federally funded multi-center pancreatitis consortia. We aim to establish a consensus of optimal guideline for the sample collection, processing, and storage. And we think our efforts will reduce the variability in the biospecimen handling and also accelerate the accurate biomarker discovery in the field of the pancreatitis. And what else do we need to accelerate biomarker research in pancreatitis? We can go back to 3 factors. First, disease states. We need to further stratify the disease groups by disease state and different etiologies and risk factors. Methodologies, we need to adopt novel sensitive technologies. We also need a standardized sample processing protocols. We also need to think about alternative strategies beyond the blood sampling, such as mucosal tissues and portal venous circulation. We also need to consider interdisciplinary approaches, such as combining multiple diagnostic modalities, imaging plus next generation sequencing plus microfluidics. This kind of interdisciplinary approach will enhance the disease detection, accurate disease detection, and also provide a comprehensive evaluation of the disease. Lastly, the cohorts. We need to use right controls. If possible, we can use more controls, not only healthy controls, but also disease controls. Of course, a larger multi-center longitudinal cohorts will be beneficial for the validation of the biomarker candidates. Lastly, I want to point out this interdisciplinary efforts to identify more reliable biomarkers will bring the promising biomarkers from bench to bedside much faster. Thank you for your attention.
Thank you. Our next speaker will be Dr. Talukdar, who is the head of the director of pancreatology at the Asian Institute of Gastroenterology, and he'll be speaking on sham-controlled ERCP trials and the management of pain and chronic pancreatitis. Here.
Very good morning. And at the outset, I'd like to thank the leadership of the APA, especially Professor Saluja, for giving me this opportunity. My title is sham-controlled ERCP trials, but there is only one sham-controlled ESWL trial, so I can finish the talk in 2 minutes. So I took the liberty to extend the horizon of my talk, and some of the aspects that I'm going to speak about has already been covered by Dr. Yadav, so it would be kind of a revision. Let's look at the evolution of therapy of chronic pancreatitis. So if you see here, several things have happened since the 1600s to the most recent times. And these red guys are the interventional development, right, from sphincterotomy, surgery, splanchnicectomy, ESWL, ERCP. A lot more, many more things have happened. But if you look at the blue guys, these are the medical aspects and the conceptual aspects of oxidative stress, neuropathy, medical treatments. So if you see, there are lots of red treatments, lots of interventional treatments. And this is still the popular way of treating these patients. Probably it has evolved over years, so people have developed the expertise and have developed the fad to treat these patients. And all these are again the fancy treatment of ESWL, ERCP, complicated surgeries. But let's look at a reality check. By doing all these things, have we been able to have a complete cure of the disease? Unfortunately, no. Can we palliate the disease in a durable fashion? Again, no. We cannot reverse the fibrosis. We cannot prevent relapse. We cannot prevent cancer. So I think in spite of development of all these decades, we are still at maybe square one or square two. We still have to understand much more to get a better treatment for this disease. So let's compare before going to ESWL surgery versus endoscopic clearance of the duct. And this has been a common thing that has been practiced all over the years. And this was a famous NEGM study published several years back where the primary outcome was Isbicki pain score. And at 2 years of follow-up, there was a significant reduction in the Isbicki pain score in the surgical arm. But when this study, patients were followed for 5 years, if you see the pink colored, pink highlighted words, the Isbicki pain score significance was gone, which means that with time, the primary outcome responses failed to endure. This again, famously quoted the ESCAPE trial. If you see here in the main paper, what do we see? If early surgery approach had a significant improvement again in the Isbicki pain score compared to endotherapy first approach. But in the same paper, if you look at the supplementary data, if you see here, the patients of endotherapy who actually underwent ductal clearance had fared similarly to patients who underwent surgery. So surgery and endotherapy basically had the same effect. Now, recently, I think in the 20th of November, this long-term follow-up of the ESCAPE trial was published, follow-up of up to 8 years. And here, surgery was claimed to be the way to go and not endotherapy first. But if we see, and in fact, the authors have themselves acknowledged few of the lapses of the study. There was non-standard follow-up. It is a retrospective nature of the analysis, only a single point data collection. And there are several other issues like more than 30% of patients were excluded, location of the stones and calculi were not described. So I think we do not have sufficient data to say that surgery is better than endotherapy early. So again, this which is better, the question comes, it's not about which is better. It's about the complementarity, the right indications, the right timing of the disease. When we do these interventions, the disease morphology, is it a panductal disease or partial ductal disease, availability and expertise and patient choice. So choices has to be individualized. Now let's come to ESWL studies. So these are all observational studies, several of them from our group. And if we look at the results, the primary outcome being pain relief. So when the patients were followed up for a duration of 6 months, 12 months, there was a very high pain relief, up to 80%, 85%. But if the same patients were followed up for a longer duration, maybe 5 years, 7 years, there's a significant reduction in the pain response up to 50 to 60% only. But as I said, these were all observational studies, and this is where we decided to do a sham-controlled trial to compare the actual ESWL treatment to a sham procedure. And if you see here, this green line diagram shows the response in the ESWL arm. There is a significant reduction in pain. Majority of the reduction happened in the first few weeks of the treatment. But what happened to the sham arm? You see a similar response in the sham arm. Statistically, of course, it was significantly better with an effect size of 0.7. So this study caters to people sitting on both sides of the fence, people who are not in favor of endotherapy. They would be happy to say, well, there may be a statistically significant response, but the effect size was very small. So is it worth it? But people on the other side of the fence who believes endoscopy helps would come up with this justification. If you see here, the patients who underwent the ESWL therapy had a significant reduction in the requirement of opiates. This, I think, is in a way an important outcome because again, the opiate has its own adverse events in the long term. So this could be a viable outcome. But again, I think it's not about sitting on which side of the fence. The main issue is much deeper here. Whatever we do, be it endotherapy, be it ESW, be it surgery, be it total pancreatectomy, if we follow the patients over time, pain tends to come back. Maybe in surgery, it comes back a bit later, giving a false impression that surgery is better than endotherapy, but it comes back. And why does it happen? So this is something that we have to understand. So probably we are missing something and we're not doing the right thing or doing the right kind of the experiments or study designs. So as I had said, the interventional treatment has evolved over several decades. And there has been a belief that, okay, there is a pancreatic morphological change in the duct or there is inflammation and that leads to the pain perception. It's a linear kind of thinking. But over the years, we have seen several studies that have shown presence of depression. Anna has a beautiful paper which showed that there is depression in this patient. We had shown that. We have also shown that there is change in the metabolites in the brain, especially something called N-acetyl aspartate in the anterior hippocampus. And that is responsible for relating the pain, the severity of pain, severity of depression, the severity of disease. There are several other factors like neural sensitization, poor quality of life, descending inhibition loss. So all these actually work in tandem. It's not like a watertight compartment that at this point patients will only have a morphological defect. So we should think beyond this linearity. So what is happening in real life is non-linear. We cannot apply the concepts of linearity like that is one stone and break the stone. That's number one. Secondly, when the disease begins, the pain it's all about pain transmission. There is inflammation in the pancreatic duct. It transmits to the spine, goes to the thalamus, and there is a relay. But as the disease progresses, there is a dynamic change in the mechanism. More and more of the brain areas like the Pepys circuit, the hippocampus, the amygdala, all these things are involved, which are responsible for pain processing, long-term pain memory, and pain responses. So as the disease progresses, it becomes more of a disease of pain perception and pain experience. So at this point, the responses becomes more and more subjective. So if we do an intervention early on in the disease, possibly we get a more accurate response of the pain or the treatment. But as the disease progresses, the responses becomes more and more subjective and the reliability of the results of the trial becomes questionable. But now, thirdly, if we look at the pain pattern, earlier we used to talk about AMAN 1, AMAN 2 pain types, but now we have 4 to 5 different pain types. And I'm showing you a real life pain pattern of 3 patients over a period of 1 year. For example, in patient 1, he had some kind of fluctuating pain between 3 months and 6 months. So if this patient, and all these patients actually are eligible technically for randomized controlled trials if we follow the inclusion criteria. But if the patient A gets into a sham treatment, he anyway won't have pain after 6 months. But the response in sham would falsely give us an impression that he had a sham response. But by natural history itself, the patient won't have pain after a certain point of time. For example, in patient C, suppose we put the patient in some intervention arm. The patient is having long-term pain, fluctuating pain for a long duration. Possibly in the first part of the treatment, he would respond to pain. But eventually, during the later part of the follow-up, he may acquire a different pain phenotype or a neuropathic pain. So in that patient, it will give us a false impression that the treatment had failed, whereas the primary intervention must have been successful. So these concepts has to be taken into consideration. So this becomes this leads to the heterogeneity of the response. So these factors, the non-linearity, subjectivity, and heterogeneity has to be considered when designing randomized controlled trials. It's not about the linearity or non-subjectivity. So this is important. So how to do that? That's where we have to make a holistic approach. We have to do a multidimensional evaluation for these patients before enrolling them in clinical trials. So most important is the pain character. We often do not go into the pain character, the change in pain pattern, the character of pain triggers, involvement of new areas. So these are some of the surrogates of neuropathic involvement or neural sensitization. And if a patient has neural sensitization, any kind of intervention trials could not be reliably interpreted. Again, we have talked about the COMPAT SF and the main COMPAT where Dr. Windsor has a big role. And now we have regional language also, which can be used for these patients before clinical trials. Again, we have enough tools. Lots of work have been done by Dr. Drews and his team, Anna from AIMS, we have the AIG and several other centers in Spain, which are looking at neural sensitization. Still an experimental tool, but still, if we refine it more, it can be a good modality to test patients before putting into clinical trials. And we had talked from Dr. Yadav about the prediction. use PQST to predict pain relapse after surgery or endotherapy. So this could be an important tool. And then psychological evaluation. Again, there are brilliant tools that can be used at the bedside, hardly takes 2 to 3 minutes. So these are some important parameters that has to be incorporated in these studies before the patient is enrolled. So finally, the take-home message would be, I think it's time we look at CP through a new lens, just not think about endotherapy surgery in a linear way. It's not about the duct, it's beyond the duct. Duct is just a small component of the entire disease. The pain phenotyping from a holistic perspective is extremely important. And taking these into consideration, I think it's right time to redefine trial designs and the trial outcomes. And the mind and the nerve should be the new targets of this disease. But thank again the APA for this opportunity. Acknowledges a whole lot of people who have been working to generate all this data, the granting agencies and collaborators. Thank you very much.
Thank you, Dr. Talakadar. Our next speaker and final speaker is Dr. Shui, who comes to us from Shanghai University, where she currently serves as supervisor of the Stem Cell Center, as well as the National Laboratory of Systems in Cancer.
Thank you for the introduction. Good morning, everyone. It's my great pleasure to be here. And thanks, first of all, thanks organizer, especially for thanks Dr. Ming Li to give me an opportunity to have a talk to go over the single cell analysis in pancreatitis. I was trained in IDA's lab. So at that time, I'm working on the pancreatitis. And when I moved back to China, I started to move my starting interest on the pancreatitis and gradually to pancreatitis-induced carcinogenesis. So in my talk today, I will including both. So which one? Next.
Yeah.
So I was trained when I work on the pancreatitis. I was training on this slide. We know the pancreatic trypsin activation is the early step of the pancreatitis. Subsequently, a large amount of the inflammatory immune cell were recruited in the pancreas. What we learned that the type and the quantity and the activity of the immune cells determine the progression of the pancreatitis. But for a long time, we believe that the pancreas is relatively simple based on the morphology and histology, we think it's almost similar, right? But actually, recent study told us is a large heterogeneity in essential and immune cell during the pancreatitis and even the homeostatic state of the pancreas, including the diverse response to the injury, a different type of injury, and how those essential response to the injury to generation or to go apoptosis, and also a large dynamic response of the immune cells, including different type of immune cells and how they how they're working on the modulate inflammation and repair and regeneration. And but for the pancreas tissue, there's a big challenge compared to other organs because we know acinar cells are very fragile. And when we do the tissue dissociation, it's easily to die to release a lot of the proteins and RNAs. And even though for the even tough, because when we deal with different type of the pancreatic disease, it's much harder because we have to adapt to different kind of the tissues like a normal acinar and all the injury acinar, or when they go differentiate as ADM cells. And today, even though there's still a lot of recent advance on this area, so today I would like to include in three parts under three different contexts about the heterogeneity in acinar and the immune cells. And we know back to the 2016, the group working on the published paper on the development cell, they use the modified SMART-seq particle to minimize RNAs. In their studying, they identify the minor subset of the acinar cell could proliferate in a long term. And but those type of cells can light up when the acinar were injured. and participate in the tissue repair. And another strategy to increase RNA quality is to use a single nuclear sequencing. And a study from Gastro 2021, and the use a snap frozen tissues, human pancreas biopsy, and use citric buffer to increase RNA quality. To compare with other cohort, we can see there capture much more cell types compared with previous database. And what they found that they uncover 3 types of the SNO cells. One is SNO reg positive, which has been identified before. And another type, 2 types is called the SNO-I and SNO-S. SNO-I is more plasticity and much linked to the ductal lineage, and the SNO-S are the more secreting function. And even more, those 2 types of SNO cells are easily lost in CP context. That's why not captured before, and indicate those 2 types of cells are much fragile. And when we're talking about acute pancreatitis and the repair, that's much harder and more challenging, because it's compared to the normal SNO, injury SNO are much harder to capture to get a high quality of RNAs. And previous when I work with IDA, we know the plasticity of the macrophage in distant context of the information, like in acute M1, in a chronic M2 subtype. And we still have a gap. We don't know how the dynamic change from the M1 to M2 during the recovery. We know the acute repeat acute will cause a chronic, right? So at that time, maybe 8 years ago, we can do is use a strategy to isolate those macrophage out and do the bulk RNA-seq. We capture the dynamic transcriptome of those macrophages, and we can understand it at a different stage of the repair. Early stage more like M2, but is working on the regeneration. But at the late stage, it's still M2 like macrophage, but function is more like preserving the inflammation damage the tissues. And later on, the work from IDA's lab, also they take advantage of CyTOF to take an even close look at those macrophage. They got 7 subtypes of those macrophage and see the dynamic change during the whole AP progression. And until now, because there's still a gap, we only can use the isolated immune cells, but we're still missing the crosstalk between those cells with the epithelial cells. Until now, just recently, a gastro paper come out. They use generate a fix and card method, and basically they use a reversible cross-link to increase cell recovery and elevate the RNA quality, and to reduce the technical artifact, because it fixed tissue first. In this way, you can decrease dissociation cost gene upregulation. And they apply this method to the more complicated context, the pancreatitis and the repair model. And in their model, in their way, they identify 2 types of the ADM cells, ADM early and late. Even more, they define the ADM score, and that can apply to other cohorts. And the most interesting part is they found the fibroblasts are transit active during the pancreas, especially in the early stage of repair instead of a later stage. So that's very interesting. And also they got a look at the macrophage. They found the inflammatory macrophage and can divide in the 2 subtypes. Argin-1 macrophage participate in the early stage of the regeneration, but the TREM2 macrophage participate in the late stage. And even more, they capture the very tiny subset of the tissue retinal macrophage. That one is more like peritoneal cavity macrophages. And so when I go to the pancreatitis induced tumorigenesis, we know for a long time there in the white type and KRAS background, when the injury happened, they will go to the ethanol to metaplastic transition. But we don't know if they're looks like similar or functional similar. And to capture the heterogeneity, work from the literature published in the Gastro, they use 2 and 4 weeks CP cerulean injection model to mimic CP. And in their model, actually, they found it's much the ADM cell much like gastric-like type. And also more interesting, they found those ADM cell can can sit in the tough cell and the EEC cells. But in the under the condition of the oncogenic KRAS activation, those cells disappear. It just switch forward to the pain-like stage cells. And even more, the study from Scott Low Lab, they push forward even in the early stage. They just use 48 hours post injury. They found at this stage we always call ADM cells. They're got chance to look at their epigenetic state because they're a toxic technology development. And they found those type cells are much more like PDAC cells. It's a big published in Nature. Is a really big shock for in this area, study area. And there must be some progenitor cell happened in this state. So so they got look at single cells and check on the epithelial cells in different genetic background and different time point. They do find a progenitor cells like in the KRAS plus 2 days cerulean injection. Those progenitor cells have high plasticity, are more like PDAC cells, can induce by inflammation. And what we are interested in also on that part, but we think about there much more heterogeneity in the ductal-like cells and maybe in the pain cells. What's the connection between them? And what we did is our in-housing experience. We do the like 2 weeks of pancreatitis model to mimic a CP and the plus KRAS mutation. We do found the 3 types of ductal cells, which one ductal 1 were marked with the Lin6D. It's more like in the early stage, we call it maybe have higher stemness. And we prove that there in the normal pancreas, those cells are not exist, but in the under the inflammation and KRAS condition, they will show up. And one use the organoids method, which found that Lin6D positive cell has much more stemness features. And we take a look back there, take advantage of the Scott Low Lab's result. We found there in the 48 hours injury, those cells are still exist as in the progenitor cell stage, and even more, they also have the stemness features. And what's more important is because the inflammation and tumor suppression are always considered as a second hit, but Lin6D positive cells are universal expressed, but in the much more in the inflammation-induced models. And whether Lin6D is, so we have a question whether Lin6D is a functional marker or just a marker. So we deplete the Lin6D in the pancreatic KRAS condition models, and we found depletion of Lin6D will largely impair the pain information. And we use the ADM in vitro method and also can impair ADM progress. And in the any clinical relevance of the Lin6D in human PDAC, so we take advantage of the human PDAC public database. We found their class 2 have the Lin6D high expressed and also have the higher stemness-like features. So that's why we think it's universal markers. And also Lin6D can predict prognosis of the pancreatic patient in their different public database and in our tissue array. So to summarize, we use a single cell sequencing to identify Lin6D population with the TIC characteristics in different states of pancreatic tumor, and Lin6D is a functional surface marker, and also high expression of Lin6D predict poor prognosis of patient with PDAC. To summarize my talk today, so we know the single cell RNA sequencing enhance our understanding of pancreatitis and pancreatic-induced tumor initiation. But we usually we do the immunofluorescence intensity to prove that the existence of those cells. But further functional validation is also required, as I think it's much more important. And the further single cell proteomics and the special omics will provide more information in the context. We will see what happens in the future. Thank you all.
Well, unfortunately, I think we got started a little bit late, so I don't think realistically we'll have enough time for a panel discussion just to get us back on time. But I'm sure all of the speakers, we have several days here, would be willing to address questions here. I don't know if next session started 11:15. I think there's a brief break. Yeah, it was the last section, the session.